Thank you, sir. Respected senior clinicians and my dear friends, before I could start my talk, I want to profusely thank my gurus here, Professor Venkatraman sir and Dr. GVK sir for giving me this wonderful opportunity. My topic of discussion is going to be hydroxychloroquine. Even though I am not a big user of this molecule, I will try my level best to do justice to this topic. Yes. So if you take rheumatoid arthritis, diabetes and atherosclerosis, the one factor which is serving as a link that is binding all these three entities is nothing but inflammation. And inflammation is not only implicated in the pathophysiology of diabetes alone, it is also implicated in the pathophysiology of atherosclerosis as well as atherosclerotic cardiovascular events. And you have a number of evidences here. You have lots and lots of evidences which is linking inflammation to diabetes here, and I'm not going into the detail. You can see so many articles, so many things are there. So now when it comes to the pathophysiology of diabetes, it is not ominous octet anymore. It is now egregious 11, and there you can see inflammation is definitely taking a predominant role there in the pathogenesis of diabetes. And in this context, if you look into what role has hydroxychloroquine in diabetes, I just want to look and see. In 2014, this molecule was approved for the use of for treating diabetes. And if you look into what is the mode of mechanism of action, what mode it acts, one thing it is inhibits your insulin degradation, it improves your insulin sensitivity, it reduces your inflammation, as well as it preserves your beta cell function. Let's go one by one. And here, it inhibits your insulin degradation. We all know that insulin gets degraded finally, that is well known. What happens here is that in type 2 diabetes, your rate of insulin degradation is actually amplified here. And what happens, when you give hydroxychloroquine, this hydroxychloroquine actually goes and inactivates your insulin degradation enzymes. Thereby it prevents the degradation of insulin so that insulin acts a little longer. And clinically, if you can see that here in this study, when you give hydroxychloroquine, there is reduction in insulin degradation as well as increase in the insulin levels. That's what has been found. Next is it improves your insulin sensitivity. Here I am going to show you an evidence. You give 13 weeks of hydroxychloroquine compared to the placebo. What you can get it here is this. These are patients who do not have diabetes. They had some features of insulin resistance. There if you give, what you can see is that your insulin sensitivity grossly increased in patients who received hydroxychloroquine, as well as your beta cell function also grossly improved in patients who received hydroxychloroquine. Not only that, there is also close to 19% increase in your adiponectin level. So indirectly it addresses your insulin resistance also. And what you can see, that another study I'm going to show you, 6 weeks of treatment with hydroxychloroquine, what you can see, after 6 weeks, there is an increase in the insulin sensitivity, but once you stop the hydroxychloroquine, your insulin sensitivity goes back to normal. And again, your insulin resistance also after 6 weeks, it decreases, but after stopping, again it goes on increasing. So that's what is there. Anti-inflammatory action of hydroxychloroquine, it is a well-known fact. I'm not going into the detail here. So I'm going to the next thing of preserving beta cell function. Here it is a study on mice, rats. Two groups were there. One group had diabetes, the other group had diabetes but treated with hydroxychloroquine. What you can see, rats which were treated with hydroxychloroquine, there was an islet cell proliferation and neogenesis was there, and your beta cell mass also improved there. This shows that there is a preservation of beta cell there. Beta cell is there with hydroxychloroquine. Can we use this molecule in prevention of diabetes? Yes, you have studies. Here they have used hydroxychloroquine for treating patients with rheumatoid arthritis and followed up the patients. You have one group who never used hydroxychloroquine at all, the other group which used hydroxychloroquine for a period of more than 4 years. What you can see is that there was a 77% lower risk of getting diabetes in people who used hydroxychloroquine for a period of more than 4 years for rheumatoid arthritis. So definitely it helps to prevent your diabetes. Data are there. Can we use it for patients with diabetes? Again, you can use it in combination with any other molecule. I'm going into the evidences here. Here on top of sulfonylurea, when you use it, what you can get is that in excess to placebo, you are able to decrease your A1C by less than 1.35%. And again, with 6 months of treatment, again on top of insulin and sulfonylurea, if you add this hydroxychloroquine, what you can get is that 3.3% reduction in your HbA1c when your baseline HbA1c is on the higher side, But important thing is that you are able to reduce your insulin dose by 30%. That is what is more important here. And again, and add on to metformin and sulfonylurea, you have an Indian data here where patients poorly controlled with metformin and sulfonylurea, they either added hydroxychloroquine or pioglitazone. What you can see here is that you have an equal amount of reduction in the fasting blood sugar, numerically more reduction in your postprandial blood sugar, almost equal reduction of your HbA1c, but you have a favorable effect on all your lipid parameters. That's what you got with the hydroxychloroquine. So definitely 2014, that's why they have indicated this, they've given clearance for to use this molecule for diabetes. Is there any CV benefit? There are no randomized CV outcome data, just 2 more slides here. So here there is a retrospective data. They used hydroxychloroquine for patients with rheumatoid arthritis. What you can see, there are 2 groups. One group did not use hydroxychloroquine, the other group used hydroxychloroquine. What you can see, after a period of 10 years, people who used hydroxychloroquine, there was a 72% decrease in the incidence of cardiovascular disease. So this is more important here. And again, all these things are because of the pleiotropic effects of hydroxychloroquine. It has a favorable effect on the lipid profile, anti-inflammatory properties there, anti-platelet property, anti-thrombotic properties there. One more important thing, forget about the lipid levels. When you give a molecule, even if it is not addressing your A1C, even if it is not addressing your lipid levels, if it is addressing the inflammation, definitely you get protection from cardiovascular point of view. Here there is a study to tell you, Canto study, where they did a study with canakinumab. What happened? Here, after a period of 5 years, they found that even though it did not have any effect on the lipid levels, 15% reduction in the cardiovascular endpoints was there. And here they were not diabetic patients, they were not cardiovascular patients. What you can see is there. So there are certain contraindications for using this hypersensitivity retinopathy in patients who have retinal problems, long-term therapy in children as well as in pregnancy. So you have to do screening. When you want to start this particular molecule, you have to do a baseline retinal screening. Then you have to do a fundal examination once a year, and of course all our patients are going to be diabetes, so you have to do anyway annual screening for diabetes here. I'm not going into the details. So take home message is that there is a strong binding between diabetes and inflammation. So when you use this particular molecule, it targets your inflammation, thereby it brings down your blood sugar, and it also has some protective effect on the cardiovascular system. That's with this I end my talk.